taken various initiatives. One such event is today's webinar, organized by Department of Computer Science. On behalf of our department, I extend my hearty welcome to our resource person, Mr. J. Ayappillai, Head of Product Management, Change Healthcare, PBS, USA, who is with us today to give us an informative talk on patient-centric healthcare administration. Hearty welcome, sir. I also welcome Dr. John Prince Soundaranayagam, IQAC Coordinator, who is with us providing the technical support. Welcome, sir. I also welcome all my colleagues. Last but not least, I wholeheartedly welcome all the participants without whom this webinar wouldn't be a success. Once again, welcoming you one and all, I request Professor Sumati, Assistant Professor of Computer Science, to introduce the resource person to this learning group. Over to you, Sumati, ma'am.
Sumati ma'am?
Sumati ma'am?
Her video is not there.
Okay. Jane sir.
Yes, sir.
Continue pananga. Department's profile. Let her join.
Okay. Hema, you please call Sumati ma'am and check her availability.
Okay.
Okay. Participants, Department of Computer Science was started in the year 1998, and in 2004 we have got our PG courses. We have started the PG courses in the year 2004. Many in-house development were carried out by our department staff members. To be particular, library management software, examination software, and account software for our college office administration. So all these are carried out by our department staff itself. So it's really proud to say that most of the software that is running in our colleges and inbuilt software, in-house software, that is built by our department faculties and students. We have a technologies council also, from which we are supporting the students to carry out their projects. At present, we have 10 members in our staff council. I think Sumati ma'am has come. Sumati ma'am,
are you able to hear me?
Yes.
Yes, ma'am. You can go ahead. And now I request Mrs. V. Sumati to introduce our chief guest.
Good evening, everyone. Today we have with us Mr. J. Ayappillai, Head of Pharmacy Benefit Solutions Business Unit, Product Department at Change Healthcare, located in Nashville, Tennessee. Mr. J. Ayappillai hails from Thoothukudi and has a very impressive alma mater. He completed his schooling in St. Thomas Matriculation School and moved on to MEFCO Engineering College to do his degree in Electrical and Electronics Engineering. Later on, he graduated from Fuqua School of Business, Duke University, North Carolina, with an MBA. His experience is vast, not only in the field of healthcare, but also in software. He has showcased his skills through various roles for 18 years in various companies such as Vidyut Metallics, Viva USA, and Accenture. Corporate planning, portfolio, and vendor management and technology strategy are some of his strong suites. His passion for defining, developing, and executing versatile business strategies has led him to achieve immense success. This journey of Mr. J. Ayappillai serves as an inspiration to people who tend to cross paths with him. It is my privilege to introduce you, sir. Thank you for accepting our request and joining with us today. Over to you, sir.
Yes, sir.
Can you all hear me?
Yes, sir.
Wonderful. Thank you very much, Sumati and everyone. It's my pleasure to be part of this group and try to give some of my insights into what we call as healthcare administration in the United States and what we want to achieve in certain other places, including India. So that being said, I would like to share my screen. Let me know if you all can see it.
Yes, sir. I can able to see, sir.
Wonderful. Is my video on?
No, sir. Your video is off. Yeah.
Okay.
Yes.
All right. So, what's in it for today? We have about an hour, and I would like to cover as much as possible. And I do have a story to tell. The story here is, I would like to, make sure that we all understand why we are here. The reason being, it is understanding what healthcare administration is. And slowly get into, the healthcare administration in the United States and how United States is doing, and get to some sort of numbers. This is all number game anyways, right? So we'll start looking at, how United States and how much United States is spending on healthcare, and do some comparison of mostly India and some connection to what the world is doing in the form of healthcare and the overall economics around it. And then we're going to be talking about the root of healthcare and the administrative costs associated with it, and where the cost is going and where the money is coming from. And how the administration spends it, and how effective it is, and how efficient it is. And then we'll talk about drugs, devices, and pharmacy benefits, which is my area of passion. I've been in this industry for about 20 years plus now, which is quite impressive for any person to stick to a single industry for about 20 plus years. And then finally, we will go into what patient-centric means, what it means to put the patient in the middle, and get to the focus point of how can we improve the patient's health condition, our outcomes, if you will, and how can we reduce the overall cost of healthcare in the form of economic outcomes to the payer. For the most part, the payer is the patient. In some way or form, the patient pays for everything. But there are other cases where the patient doesn't pay for it, while the community pays for it in the form of taxes to the government, and the government, takes care of their population to make sure that their population is healthy enough. So that's the goal for today. That being said, let's go into what is healthcare administration. Healthcare administration is a very, very broad area of study. Many universities offer a 4-year degree course here in the United States, and it is becoming very popular. And there is a lot of master's degree courses too in healthcare administration if anyone wants to pursue. So that tells us that this is a vast area of study, and we have an hour to cover everything. So we'll try hard, right? We'll try hard to get to the breadth of it, if you will, and not get to the depth of any of these areas, right? So there may be some questions after this call or after this webinar. And if you all have any questions, we have a forum to have a conversation on it. If you want to go deeper into any of these areas, because within the time limit that we have, we will not be able to complete everything that encompasses healthcare and its administration. So, the high level goal is make sure that the healthcare is effective, the whole administration is effective and efficient to providing economical and health outcomes for the patient. That's pretty much what you need to take away from this. So why is it so so big, so huge? What is going on in it? So I've listed some of those reasons, some of those concerns that healthcare administration is looking to target these days. It is huge, we all know that, and if you look at technology, technology adoption usually happens in financial industry first, right? If anything new comes, right now lately it is the social industry, like social networking, which adopts to technology faster than anything. But in the past, it used to be the financial industry. Healthcare industry is always very slow in the form of adapting to technology. However, that cannot be the case. We got to adapt. Healthcare industry is moving fast right now, and the technology is going ahead exponentially. So technology is advancing. And the third thing that I wanted to highlight is the payment process, right? Who pays for services? Who's trying to pay for it is primarily used to be like, if you look at in India, about 54% of Indian population don't have access to any healthcare insurance. So they pay themselves, it's just coming out of their pocket. But in the United States, it's the opposite, right? We have about 80% of the population that has access to some form of insurance. So the finance is moving from personal pay to like a third-party reimbursement system. So that's the challenge here. And government is taking a larger role, and we have to administer those, right? So that's another thing that we need to be focusing on from an administration perspective. And of course, right, patient safety and quality. After all, everything that we do here is about patient safety and quality. When we say quality, we want to make sure that the patient walks out happy and gets out of sickness sooner than later. And we need to take care of our aging population. That's one of those considerations that the administration is looking at. And, rapidly changing technology in the form of healthcare too, right? If you look at the way we treat people for a condition 15 years ago versus today has changed completely, and we need to adapt to that. So if you ask what is healthcare administration, administering all of these things, taking into consideration all of those things we just talked about, not just this, but more than this, I just highlighted a few here, is exactly what healthcare administration really needs. So I want to pause here and get a feedback on how fast we are going, and if this pace is good enough, if this is exactly what we're looking for. Anybody that has an unmuted mic, if you could provide a little bit of feedback on, if we're going at the right pace, then that sounds good. And if I'm talking too fast or if I'm talking too slow, that would help me to pace this thing.
Yes, sir. Sir, you are going in the correct pace, sir. You can proceed, sir. Any participant, do you want to have any suggestion? You can just raise your hand. I can unmute you.
Wonderful.
Okay,
Wonderful.
sir.
So nobody
okay,
raised their hands, right?
Yes, sir.
All right. We need to make use of this time as best as possible. And yes, of course, we will open it up for questions at the end of it, and I will open it up for questions like after every session or logical session, if you will. So the healthcare system as a whole, right? This is the view from the moon, right? I wanted to call it as a view from 30,000-foot level, but this is not even a 30,000-foot level view. This is a view from the moon, right? If you look at healthcare system from the moon, this is how it looks. And then that's the level that we can be at this point in time, just because this is a high level introduction to this audience. So we're looking at healthcare, and I on purpose put the patient in the middle, right? And of course, everything is all about the patient's welfare and healthcare. So if you look at it, the components, the participants of the healthcare system. So if you look at it on the left-hand side is the payer side of the equation, and on the right-hand side is the service side of the equation. To my left and to your right. So if you look at PBM and pharmacies and providers, that is the service side of the equation, and employer group and payers and federal and state governments are the supply side. So let's talk about each one of these, right? We all know who the patient is. The patient is us, right? Anybody that is looking to be healthy or that is sick and want to get out of sickness, and maybe if you are catastrophic conditions, like you met with an accident or you have a heart attack, you become a patient, right? So those are that's exactly what a patient means, and that's how we define patients and members. On the right hand side, you see providers, right? Providers in this ecosystem are the doctors, the nurses, the care providers, any kind of care providers. Your care providers could be your physiotherapist, your nutrition advisory system, or or a person that advises you in any form of healthcare and gets you pay for them is what we call as providers. And if you go to the top here, PBM, pharmacy benefit management is exactly what that means. And pharmacies, you go to a pharmacy, and drug is a big, huge entity. Drug, pharmacies and pharmacists are a huge entity, and they play a big role in your health, in your outcome of health, if you will. So these are the service providers on your right. And then you go back to your left-hand side. If you don't have any insurance, if you don't have any employer group, pardon me? Okay, I'm getting feedback from here. So what? I'm sorry. All right. So I'm sorry, guys. I just got interrupted here. There were some folks here that's looking at me. So again, going back to the flow here, on your employer group side, what is an employer group, right? You work for a company, and the company provides insurance for you, and the company takes money from you, and you get insurance as a benefit. And the payers are your employer groups here, like here. Your employer group work with your payers here to make sure that your healthcare is administered properly. So when we talk about healthcare administration, this group here, this blue box here, plays the biggest role. Everybody else plays a role too, but this guy is an administrative role. Payers play the biggest role in health administration. Providers play the biggest role in the clinical outcome of everything that you do. So that being said, and then you see here, your federal and state health benefits is another provider, right? They pay for you, and in general, these are the entities that really play a big role in the healthcare ecosystem. And like I said, there are thousands of other entities out there, if not more than thousands. But this is, looking from the moon. These are the three or four entities that I would want to highlight for this group here today. So let me move on to who's funding it and where we are getting the funds from. As far as U.S. healthcare system is concerned, the cost. Let's not focus on the distribution yet. Let's just focus on the number here, right? This is not a recent research though, but this is a research that came out in 2014. But I just wanted to show you guys where we are, right? If you look at it, we are, in 2014, we were spending about $3 trillion. As when I say we, it is the United States.
Sir, sorry for interruption,
Hello?
sir. Sorry for interruption.
Yep.
Sir, your slide is not moving. Next slide, sir.
My slide's not
see.
moving?
Yeah, we can see only what is health administration. That's the single slide we can see.
Oh. I am moving it though.
But it is here. It is not getting moved.
Okay, let me see if that has changed. I took it out of presentation mode. Did it change? Did anything change?
No, sir. Still, it is in the same.
GN sir, just close it, sir. GN sir, you share one screen. GN sir.
Yes, sir.
So let me
now
stop
it's okay.
sharing.
Okay. That's start from the beginning, sir.
Okay.
Yeah.
Can you guys see me?
Yes, sir.
No, start the slide, sir.
Okay.
Okay, make it as a full screen.
So
On your video.
all right. Okay, so go back to my video. All
Yes,
right. All right. So I apologize. And I think this is exactly what my peeps were trying to tell me. I didn't get it. And I was looking at them and I was like, they said the slides are not moving. I'm sorry. I apologize for it. It was working for me. So it just didn't, Zoom, I think sometimes could cause some issues. Let's just move forward, right? So this is the screen that I was talking about. So I know you guys were stuck in this screen, right?
Yes, sir. Yes, sir. Go ahead.
Okay. And then let me quickly, show you guys what this is, right? So I was talking a lot about this slide, and I thought that you guys were able to see it, so that's fine. So this is the slide that I was talking about. I was talking about the providers here. The providers are the doctors and nurses and all the caregivers, and this is the pharmacies, and this is the employer group. The patient works for the employees and employers, and they get the benefit, and they go to the coverage, payers to administer their benefits, and this is the payers are the ones that take care of healthcare administration for the most part. And these payers pretty much administer everything, for the patient, for the providers, for the pharmacies, and for the employer group. So these, the shift was this payer guy, was in the middle until recently. So now, the goal is we're switching to put the patient in the middle, and that's why we want to call it patient-centric healthcare system lately, but not payer-oriented, right? It's all about payment. And at one point, like 5-6 years ago, everything was about money. But now things are changing. People are putting patient in the middle. So that is the gist of this. I know you guys were handicapped and not looking at this picture though, but hopefully it helps. So now, is my screen moving?
Yes, sir. Yes,
Okay,
sir. We can
good.
see able to see the
Wonderful.
pie chart.
Wonderful. I apologize. Really sorry for what happened. So here in this particular slide, I don't like to go from a slideware perspective. So what you want to take away here is, I'm going to explain about the components in a different slide, but just look at it. Like in 2014, United States was spending about close to three and a little over than $3 trillion in the overall population's health. And if you look at it now, in 2024, the expectation is the United States will spend about $5.4 trillion. Trillion, with a T in it, not a B, right? So that's a lot of money. That's a lot of money. I'll do some comparisons later. But if you look, that's the focus that I want you guys to take away in this particular slide. So looking at it, our spend, this is prescription spend, is about 10%, and government spends about 52%, close to 52% of everything. Like government just spends 52%, about 52% of the overall cost of healthcare. So that's what you need to take away from here. Let's move on to the next. So this is where I want to highlight where the funds come from. Primarily health insurance is about 75% of the overall money, that comes from, right? Health insurance is, when I say health insurance, this includes government funding too. If you go here, about 34% of this 75% is private health insurance. Medicare is again a program offered by the government. But it is for the older people, like the retirees. When people retire, they will have to go to the market and buy this Medicare insurance, which is partially funded by government through retirement funds and Social Security. And then Medicaid is for poor people. Like if you look at it, 10 plus 6, about 16%. Of the overall spend, like I'm talking about $3 trillion, right? So is going for the poor people. And then if you look at the small, 4%, which is Veterans Administration, which is primarily retired military people, Department of Defense, which is like active military, Children's Fund, and as such. So this is what the insurance component of it is, and I wanted you guys to highlight this, right? This is about $350 billion is spent out of pocket by individuals in the United States. So let's move on to the next slide. So so we got so much money, right? $3.6 trillion. Now let's see where the money is going, right? So this is the component which is crazy, right? If you look at it, about 50% is really what's going to the hands of your caregivers, your physicians and hospitals. Pretty much get about 50% of everything we spend, and the remaining 50% is going, ignoring the prescription drugs, right? Everything else is going in some way or form to the administration. So that is huge. That's a lot of money that is being spent on administrative things rather than directly going to the doctors and the hospitals. So that's something to make a note of. And that is why this market is huge, very big. The healthcare administrative market is very big. So let's look at, the other field here, right? So, what that other constitutes to. We do a lot of durable medical equipment and non-durable medical equipment. I want to talk about home health care, right? If you look at it, 3% of the overall 14% is exactly what's spent on home health care these days. But that is changing, right? Especially, if you look at today's COVID situation, they won't allow every COVID patient to the hospital here, because that's just not possible. The hospitals don't have enough beds, especially at the rate we are having. The COVID is expanding, especially in cities like New York. it's impossible for the hospitals to handle it. So home healthcare is a thing. Since we had the structure and framework for home healthcare, we were able to do that, and that is another thing that I would want to highlight that really helped. If you look at today, home healthcare, this percentage would have changed. So this is where the demand for funds goes. Where the supply comes, where the money comes from, where the money goes. So let's do some comparisons here, right? So this thing is the overall world economy, right? The whole world produces $107 trillion. Okay, 107,000 trillion dollars. And if you look at it, U.S. healthcare alone, spends about, $108 billion. The whole world economy is, and U.S. healthcare alone spends about 3,000 of it, which is close to 3.2% of the overall, GDP of the world, which is a lot of money. 3% of the overall, the money that's available in the whole world. And that is something that I wanted to highlight just to let you guys know that it is that big. And if you look at it in a different angle, just to do another view of the comparison, is the U.S. healthcare system, if it is a country, right, it would rank number 5 in the overall, GDP. And you can see where India stands. India's GDP is, this was done in 2015. I know India has crossed France, and India has crossed UK recently, I think. India's economy is growing faster, but in 2015, United States healthcare system was number 5th in terms of overall GDP across the world. So this is to just give you all an understanding of the magnitude of money that is involved in this. So let's talk about India right now, right? So, I don't have a lot of India slides and research, only because I've been, in this country for about 20 plus years now. And I did do some research before I walked into this webinar, and I wanted to highlight what's going on in India as far as insurance. This was surprising to me, and I'm sure that this will be surprising to some of you guys too. If you look at the insurance penetration, right? India, in my opinion, like when I was in India 22 years ago, there was no concept of insurance. There was no concept of health insurance. We people had to pay out of our pockets, and there was no administration. It's just, I know my doctor. I still remember my doctor when I was a kid in Chidambaram. We used to go to him all the time, and we had a relationship with him, and he knows us by name, and that is how India was 20 years ago. And my knowledge about India is frozen right now, right? I moved out of the system, and it's been 20 years. And right now, if you look at it, I was really surprised to see there was about 26% penetration in 2010 in terms of like population that had some sort of insurance in 2010. And if you look at it now in 2020, the population that has access to insurance right now is about 45%. Imagine 45% of like 1.34-ish billion people is a lot of people. So you can see that that's about 655 million people that currently has some form of access to insurance. That is amazing. That means healthcare administration is growing in India. It only tells us that administration is growing, but without access to knowledge and information about what healthcare administration is. It is an opportunity. People should see that as an opportunity and take healthcare administration as a career option in future. So that is one of those things I would like the health and the education system, especially colleges like you guys, should look into this as an opportunity. There's a lot of money that's being spent, and there's a lot of opportunity out there. The insurance market is growing here, which is good, in many ways. I'll talk about the bad in future, right? in a couple of slides. But this is one of those things that I learned, and this was a surprise. I learned it the day before yesterday. So I wanted to bring it to this group. And this is a research that was done by McKinsey. And as I was searching for it, I was able to find some. So the other thing that I want to highlight here is, what is government spending? Like, where does, I was curious, and I started doing some research, and I found that also in the same paper. Share of GDP as government spent, right? So if you look at it, government spending is also increasing, and that is natural, right? People are more educated now, and they go ask their government to make sure that their population is healthy. So, we can produce more, and we can be a better economy and become a better country overall. So if you look at it, government spending is consistently increasing, and right now it is around $11 billion. No way we cannot compare it to what the United States is doing today. And I'm not here to say or judge if this is good or that is good, but my next slide is going to tell exactly what it is. But this is an idea of where the health system is going in India. The health market, the healthcare administration market is going in India. A lot of money involved, a lot of administrative costs involved, without a lot of education and awareness, right? People need to be aware of this as an opportunity. So let's move on to next slide. Okay, let me pause here and do a time check. It's about 9 o'clock. Let me try to rush as fast as I can because I lost some time. What is this? Like, we have seen, oh my gosh, the United States is spending about $3 trillion. We've seen United States healthcare. If it was a country, it would be the fifth in the world. And all of these, if United States is doing so much, everybody in this call must be wondering, right? Oh my gosh, United States must be the healthiest country in the whole world, right? This is the outcome. Look at it. United States, is not in the top of the list, not even close to the top of the list here. United States health outcomes, performance ratings, and if you look at it, is in the bottom of the pack. The pack being, right, comparable countries, right? So it is not comparing itself to countries that don't spend as much, or it is per capita spend is the biggest consideration for countries to be in here, not the overall population or anything. India would be there, and China would be there if that was considered as a criteria to measure and compare. But that is not. It's per capita spend is what's considered. Looking at comparable countries that spend a similar amount or closer amount to the United States, U.S. is not performing well. What is that a surprise to you guys? U.S. is really bad. They spend a lot of money, but they don't perform as well. So that is where we have opportunities. So that being said, let's look at some of the reasons, right? So we're looking at lack of coverage. Again, I said 80% of people have some sort of insurance, and 20% don't have any insurance. Compared to this in India, right now, as of 2020, about 56% don't have insurance. So that's the difference. And if you don't have insurance, especially in the United States, people are really poor. They don't have a job. They are not eligible for Medicaid. And most of them are immigrants or people that are not eligible for any kind of social benefits. Which means those people are in the market, in the hospital system, but they just cannot afford to pay for anything out of their pocket. And it will be amazing in how the market pushes it, right? For example, I can go to a lab here and take an X-ray, and if I had to pay out of my pocket, they would be charging like $4,000. I'm just making this number up, And if I go through my insurance, they would be accepting $10. It makes people, it pushes people to insurance, and that is their marketing strategy, right? So clearly, people who are out of this coverage list will have zero access, literally zero access to any healthcare provider, because the healthcare providers don't want to jeopardize their money, their revenue coming from the big insurance companies and the state governments, right? So they just say, if you want health insurance, healthcare, just go and get an insurance. And these are the people that cannot even afford it. So that means poor people are there in the United States, and poor people cannot afford any healthcare, literally zero healthcare. That means we're going to underperform, right? Obviously. And administrative inefficiency, right? There's, when we're talking about in our previous slides, we talked about $3.5 trillion, and about 50% really goes to the doctors and the service providers, and that means about $1.5 trillion. $1.5 trillion is being spent on administration, and inefficiency there. Like look at opportunities. Clearly, there is huge inefficiencies out there, and there's room for improvement there. Fraud and abuse, yes, it's always there. It's everywhere, right? We are people, right? We are tend to do fraud and abuse the system, and that's there. Primary care underperformance, that's normal, right? I don't want to focus more on that. But the thing is, the administration, the overheads, and everything that we do here may look like, oh my gosh, this is a much more advanced country. But if you look at from a patient perspective, from me, like if I'm looking at myself, we are not far better. People in India are much better because it's if you don't have an insurance, you can still afford a doctor, right? You can walk up to a doctor, and then the doctor really takes care of you, and you will be paying a reasonable amount to the doctor, which is amazing, right? That means there's a lot of consumerism in there. Here, when we have insurance, there is literally no consumerism, right? I can't decide which doctor I want to go to. Somebody else sitting in Los Angeles, California, is deciding who Jay needs to go to a doctor if I get sick, right? Which is, I don't have any control of my health, at least in some ways or form, right? But that is changing. But that is changing too. But again, we all are, when I say we, like we Indian people are all blessed in many ways, right? So to have this consumerism in our hands, like we control everything. But when insurance takes over, right? Slowly we saw that slide where insurance was picking up. When insurance takes over, that is going to change. But at least until then, right? We have the power. We have the power, and we tell the providers. We go to a doctor and tell them that this is what I want. You do this service to me, and the doctor does it, and we pay for it and we walk away. So that's a lot of control out there, which means there's two schools of thought, right? Consumerism may help increase the outcomes. Administrative, efficiencies may increase the outcomes. But I'm not here to judge which one is better. Right now, we are in a system in the United States. This is a system where consumerism is not there. It is coming up, but it's not there. Putting patients in the middle is not there at all. In India, we have that control. So that's something that we all need to take away. And after all, we are not in a place where nothing works. We are in a place, we have to be proud of being an Indian. We have to be proud of our systems. Every system has opportunity to improve, but you cannot blame your own system unless you take responsibility, you take ownership, you take stewardship, and do something about it. We can't blame somebody else. We can't blame the government to do things. We can't blame our universities to do things. We can't blame our doctors to do things. We can't blame our nurses and pharmacies to do things. There's opportunities out there for us to do things. So let's look at that as an opportunity again, right? So that being said, let me take a break, and I'll pause, and I'll go back to the organizers here. And
Yes,
see if there is any questions, and if we are going at pace.
Yes, sir. Participants, if you have any question, you can raise your hand. Yes, there is a question. Yes, Selvi ma'am, go ahead. You are unmuted. Yes. Do you have any questions? You have raised your hands. No, she has muted herself.
Hello.
Sir,
Hello.
Ayadure sir, yes sir. Go ahead, sir.
Sir, what is the role of the producers in US and India?
Sorry,
Can
sir,
you
I
compare the
couldn't
role of
hear you
producers in
properly.
India and US?
Sir, your voice is breaking, sir. Ayadure sir.
Sir, what is the role of producers?
What is the role of
India and
producers?
US? Can you compare?
What do you mean by producers, sir? If you could explain what a producer is.
It is the medicine manufacturing companies.
Oh, big time. I'm getting there, right? That's actually next. But I will answer your question right now, right? So the role of drug manufacturers is huge. The world is dependent on India and its manufacturing capabilities, especially when it comes to generic drugs. I am going to talk about it in my next slide. Can you wait till I present that, and then we can have more questions? Excuse me. That's next. You just are thinking ahead of me. I'm going to talk about that right now. Any other questions?
Sir, the patient-centric
All right.
administration system in India is better than US or worse than US?
See, if there's two ways to see this, right? I see it as better and not better, right? When you say when I have control of my healthcare and you are economically there to control it and pay for it yourself, it is better. But for example, if you want to go to a doctor, and the doctor and the service that he might want to perform on you is beyond your reach. Say, for example, if my total savings and my total borrowing capacity is $500,000, and if I had to go to the doctor and the doctor says your cost of care is going to be $1 million, I just will not be able to pay. So at that point in time, there's no point in having consumerism, right? Because I just cannot afford it, so I'm going to die. However, on the other side, when you give up consumerism and somebody else administers it, there is an underwritten thing, right? There is a risk that is underwritten. So there is good and bad in both. And there needs to be a balance, would be my answer.
Hello.
Yes, sir.
Yes.
Hello.
Yes, sir. Yes, sir. Go ahead, sir.
Okay, sir. Thank you, sir.
You're welcome. So let's move forward. I only have about 9 more minutes left, but can I go a little longer?
Sir, yes, sir. You can go, sir. No problem.
Wonderful. That's good. So I don't want to keep you guys captive for a long time because sometimes these things could be boring, right? So, and it's a passionate subject for me, but I can't expect everyone to be passionate about what I am, right? So, so again, let's dive deeper into the question here that was posted, right? Drugs, devices, and pharmacy benefits. Oh my gosh, drug spend is about 10% of U.S. overall healthcare spend. And right now, U.S. is spending about $3.5 trillion, and 10% of that is about approximately $350 billion in the United States. But if you look at in India spends about $55 billion, or is expected to spend about $55 billion in 2020. in drugs, in overall drug spend. So that is the difference, right? And again, there is purchasing power parity difference here. The money value in India is not the same as the US dollar value. So typically manufacturers don't sell, the cost, a cost of a certain drug will be very high in the United States compared to the same drug in India because the purchasing power and the parity around it, which is very good, right? The manufacturers, the drug companies really consider the buying power of Indian population, and maybe that is why it is low, but you never know. So think of 3 times the population of US spending about 8-9 times the money that US spends, right? So which is not a good number to compare, but again, you got to use your own your own thought process to see how that balances. But purchasing power is considered in these numbers. So the 2 big things that I want to talk about is this is the takeaway for us, right? For us, this is where we could be smart. As patients, we could be smart. Specialty pharmacy is like very expensive drugs, right? An administration of chemotherapy. Chemotherapy is done for cancer patients, and those chemo drugs are like crazy expensive. And there are certain health conditions that really demand a very high cost and high touch point drugs to be administered by the physician, which is, that's only 4% of the population, right? So we only have about 4% of the population that needs that kind of specialty drugs. And those specialty drugs cost about 25% of the U.S. drug spend. And then, again, for most of us, hopefully, right, we don't have to go there. But if we ever have to, then we'll have to deal with it. Let's look at this right side of the slide here. This is a very important slide. If there's any one thing that I want you all to take away from this whole presentation is this one. So pay a lot of attention to this particular thing. That is why I kept it in the last, right? It is very, very important. So look at this, right? There is, and it was a very good question, whoever that asked it. There's drugs, right? When you say drugs, let me explain a little bit about the drug market, right? How the drugs come into market. Drugs don't just automatically come out of the blue, right? So we have to do some research. There are certain companies that, like Pfizer and big drug companies, really do spend a lot of money in research to go find or develop new drugs. And in the process, spend like tons of money. And then finally they come out and say, well, you know what, FDA approves it, and this is a new drug, and this is going to do wonders for a certain patient. And it comes out in the market, and the cost of producing that could be $10 per pill. But the investment that went into that drug is like maybe $1 billion, right? So the cost of production is $10 per pill, but they invested $1 billion in the production in the research and development of it. So that particular drug cannot be sold for $10 because they are producing it for $10, right? So they go to the government and FDA and say that I want a patent for this. And when they do a patent, when they get the patent, when FDA approves it, it's just that manufacturer that can produce that ingredient. And they can sell it in the market for about 14 years. And then they become a brand, right? So that is a brand drug. So what is generic drug? Any drug that is in the market for 14 years and then goes out of brand, right? Out of patent. That is when the Indian drug manufacturers come in. The Indian drug manufacturers come in and say, well, I can be a generic manufacturer for this drug, because it passed patent. And they go produce it, and they, like if it is sold for $10 or $100, whatever dollars, they may be able to sell it for a penny or a few dollars, because they don't have any of the overheads in the form of research and development. All they have is they know the compound, they can go and create the compound, put it in their production line, get it out, right? Put the raw materials in, get the pill out, and they can go sell it to the market. That is how Indian drug companies are. Most Indian drug companies are huge in producing generic drugs. In U.S., drug companies are big time producing brand drugs. The brand drugs are expensive, right? When you walk into the physician and the physician writes a prescription, physician is typically, don't take my word for it. If the physician is really good, and if they care for your economic benefit, they may write a generic prescription for you. But for the most part, they write a brand prescription for you because they might get a cut back, right? I did not say that, right? So don't quote me on it, but that's what happens behind the scenes. The doctors will write a prescription for you. Chances are it is a brand drug. So brand drugs are expensive. And the one thing that you could do is you could talk to your doctor about it. The minute you get a prescription, you should go to your doctor and say, "Hey, doctor, is this a brand drug?" And the doctor might have an answer, and he might try not to answer it too. But if he doesn't, right, you go to a pharmacist. And the pharmacist is also incentivized, right? That is the problem here, right? Everybody is incentivized to make money. The pharmacist is also incentivized to sell a brand drug to you because it's expensive and his margins are high, and the doctor gets a cut. So who has it? Whose responsibility it is to redo the research and see if that particular drug has a generic equivalent? That is very, very important. We need to look at it. We need to say if the prescription is good, if the prescription is a brand, then is there an opportunity to go find a generic equivalent for it? And if we find a generic equivalent for it, go for it. So that is one of those things that I would advise you guys. But when I say go for it, you don't go buy it on your own, right? You go tell your physician or your pharmacist that I want a generic equivalent for this. And if you're not giving it, I'm going away. You walk away from that pharmacy, go away and talk to another pharmacist out there, talk to your friends who is a pharmacist, talk to your well-wishers who are pharmacists, and ask them if there is a generic equivalent available. And if it's available, amazingly, you will save a lot of money. So just this chart tells you guys what it is, right? Generics account for 85% of the prescriptions done in India because of administrative costs. The health administration takes care of it for them. This is a benefit of having an administrator around you, right? They want the cost to be low. So they make sure that they give you the cheapest drug. And generic drugs are typically cheaper. So 85% of prescriptions dispensed in the United States is generic drugs, and it only costs about 15% of the total drug cost. And if you look at the other way, right, 15% of the prescriptions is brand drugs, right? You can go buy any brand drug, and 15% of the prescriptions is really brand, but they cost about 85% of the overall pharmacy sales. So this is the most important thing I want you all to take away. Everything else is administrative thing, right? This is where you benefit. This is where we as a patient gets benefited, and this is one of those important slides I want you all to take away. And I'll pause here, and this, I know that there will be a lot of questions here. If there is any questions, I'm ready to answer because this is my area of expertise.
Sir?
Any questions? Anybody raise their hand?
Sir, yes, sir. Sumati ma'am? Sumati ma'am?
Yes.
Your uncle want to ask a question you have mentioned in the chat box. You can go ahead, ma'am. You can go ahead, ma'am.
I am Jairam from Tutugrain. I want to the allopathic medicine or herbal Siddha medicines, which is cheap and best in India.
Physician writes the prescription. Physician is typically, don't take my word for it. Oh, it's a very good question. Can you mute Sumati, madam?
Yes, sir. Yes, sir. I have muted.
Okay. Okay. So, thank you, Jairam Chittappa. He's my Chittappa too. So, and this is a very good question. Unfortunately, I am not a clinician, and I'm not a allopathy or I'm not a clinician. I'm not qualified to answer that question. I wish I could. Sorry, I don't have an answer for that question because it's out of my scope of intelligence and knowledge.
Lawrence, sir, you are unmuted. You can ask your question.
Sir, do you think that Indian healthcare system is patient-centric?
At least 54% of it is yes. I'm not sure about the 46% that have insurance right now, but at least 46, about 50 plus percentage of population that has no insurance is patient-centric.
Dr. Chellaya, sir, you are unmuted. You can ask your question.
No, sir.
Okay, sir. You have raised your hand so that I have unmuted you. Sir, there are some questions. Sir, there are some questions in chat box. I will ask this question, sir. Sir, under allotment of funds to healthcare triggered a huge loss in USA. Give your opinion, sir.
Let me ask some more clarification there, right? Under allotment of funds, I wouldn't call it under allotment of funds, right? It is an efficiency issue. When a country spends about $3.5 trillion in healthcare, I don't see that as under allotment at all. I don't know what that particular person really is looking to get out of this under allotment, and I don't understand under allotment. There is a lot of money out here, which is not being managed properly. I have a perspective on, there's opportunities, right? About $1.5 trillion is spent administratively, which is a lot of money, which could be repurposed towards clinical outcomes. And the assumption and the goal is to make sure that this $1.5 trillion is helping people, the other half of it, right? The physicians and the nursing homes and the nurses do their job better. So it's almost like one person monitoring one doctor, right? So it is not. There is inefficiencies out there, but I don't know if, what he calls as under allotment of funds.
Okay, sir. Sir, Dr. Mohan, he has raised a question. We have a very poor healthcare in India. How can we develop?
What do you mean? What do you mean by healthcare, right? Indian healthcare is amazing. We have to be. That's one of those things that I wanted us to be proud of, right? Indian healthcare is amazing compared to the rest of the world. When compared to within India, right? Certain people, certain population does not have access to that amazing healthcare that India provides. Indian doctors are amazing. Indian nurses are amazing. There are, I don't agree with that statement. And there's areas for improvement out there. But if you look at healthcare, health tourism to India is increasing like crazy. Okay. So people believe in Indian healthcare system. That's why they come over there and do their treatments like heart transplants, knee transplants, and medical tourism is growing like crazy. So I don't see if that statement is valid. Okay. But if the person can qualify, what he really means by Indian healthcare is not good, I can try to answer that.
Okay, sir. Sir, one more person, Miss Sonia Rani, she has asked, both generic and branded drugs work in the same fashion. Is there any difference between generic and branded drugs? The work in which Yes, sir. Yes, sir. Go ahead.
So if I understood your question correctly, you're asking if the same component produced by a generic manufacturer versus a brand manufacturer, is that any difference, right?
Yes, sir.
Okay. If that is the question, my answer is 99.99%. There is no difference. It's the same because from a chemical components and ingredients perspective, it is the same. But it is being manufactured by an experienced manufacturer, right? So if I'm doing a thing, like don't think of healthcare, don't think of manufacturing medicines, right? If I'm doing a thing for 14 years, and if somebody comes in and I train them to do this, and they go and do it in their first day, obviously there are going to be some quality differences, right? And other than that, I don't see why that will be any different, right? It's just my experience. I've learned a lot of things in the last 14 years to how to produce it, and how well to produce it, and how to increase the quality of my product. But that new person that is producing this new drug is brand new in the marketplace, right? So that is the only difference. Other than that, it is the same component. It's the same compound.
Sir, Ms. Tangam Moses, she has asked, what are the insurance benefits for COVID-19 death victims in US?
COVID-19, everything is it's the same. It's another condition, right? So if I go to the doctor today, and I do have insurance, my family have insurance. So when I go to the doctor today, my health insurance company covers it. And if I don't, the state and the federal governments pick it up for us. So that's as far as COVID is concerned, we are fully taken care of. And as I said previously, like there's no room for everyone in the hospital. So if you don't have a lot of symptoms, you will be treated in your own home, right? So you might be given some medications based on what the doctor thinks is good for you. And you go home and take care of yourself. So there's it's status quo, nothing changed for just COVID.
Okay, sir. Thank you, sir. So these are the questions posted
Sir,
in the chat box.
Sir, one more question, sir.
Yes, sir.
Yes.
Who plays a major role in the healthcare administration system, whether the provider or manufacturer?
Let me go back to the slide here, right? Everyone plays a role, right? If you have insurance, this guy here, the payer side, plays the biggest role. And if you don't have insurance, it's the relationship between the patient and the provider. So you as a consumer have more leverage at that point in time. You can actually shop for providers, right? You can go to a doctor, I don't know if I should say in Tamil. I don't know how many people don't understand Tamil here. We all say that, right? Rasiyana doctor, right? We always go to our Rasiyana doctor, which is not, which is good, right? We can pick and choose. So the goal is to bring the patient in the middle, put the patient in the center. But sometimes the providers have leverage, right? Some providers are smart. They're focused on making more money for themselves. Some providers are really, social health enthusiasts. They just want to provide service. Doctors, there are very few of them lately. Unfortunately, though, they don't do a lot of service. They do it as a business these days. So it is the patients and the providers that needs to be focused, and the pharmacies too. Like if you are a brand and if you have a pharmacist, and the pharmacist if his intention is to make money, he's going to try and push and sell brand drugs to you because he could make more money. And if you are smart enough, then you can actually have a negotiating point there.
Yes,
All right,
sir.
there is I know I already took 12 minutes over,
Okay.
but I am free. I am available. I can go on. I had a couple of more slides.
Okay, sir. Oh,
I can talk about that too, but that totally depends on the audience and how interested they are. I have 2 more slides to go.
okay, sir. Go ahead, sir.
Okay.
Yes, sir.
All right. So now we're talking about putting patients in the middle, right? So again, this is all recent. If you look at it, this technology has changed. Technology is amazing these days. Everyone has a smartphone.
That slide is not moving,
Right.
sir.
Okay. Can you not see it?
No, sir. We can see only drugs, devices, and pharmacy benefits. That slide only it's visible to us.
Okay, let me go back. I'll do the same thing.
Sir, your audio and video is not visible. Yes, sir. We have got your video, but your audio is not. We are not hearing your audio.
All right. Can you
Yes,
hear
sir.
me now?
Yeah, yes, sir. Now clear, sir.
Wonderful. So I think there is a timer or something. So let me share my screen, your entire screen, share it. All right. So
Yeah, yes, sir.
okay. I had to do this sometime back, and I think it times out after some time. So, all right. So going back to our slide here, right? We want to put patient in the middle, and we, it doesn't mean that we, when we say patient centric, the patient can have the physician or the care provider in the middle too, right? The relationship between the patient and the doctor is something that cannot be pulled out. It has to be together. So there are tools out here like everyone lately has a cell phone or a smartphone, if you will, right? You can download apps, and there's consumer wearables right now that communicate to your phone and provide you information about how healthy you are, how much information you can collect, and if you have a health condition, there are lots of apps out there that you can download and monitor your own health, and data is amazing, right? Data and insights from the data that you can get out of it is amazing. So make use of all of those digital health tools that's available right now. I want to show you this slide here. There is like thousands and thousands of mobile apps that is available for us. If this gives a distribution of how what kind of outcome that these apps are targeting. It's about 28% of the apps that you can download at your hand is targeting mental and behavioral health. That tells how important our mental and behavioral health is. And when we don't even consider, many of us, I can tell you guys, many of us don't even think of mental health as a health issue at all. because it's important that we take care of our mental health. And if you feel depressed, if you feel tired, if you feel something that is not related to your physical health, take care of it immediately, and you have lots of tools available for it. And then the second biggest thing is diabetes, right? In India, diabetes is big. And diabetes patients don't take it easy. It is important that you take care of your your diet, your exercise, and all of those things that's related to your diabetic. And diabetic is a condition. It's not a disease. People need to think of it as a condition, and you can manage it, and you can take care of yourself. And there's a lot more, right? Like 4% of these apps target your digestive system. I was like, how would anyone think that our digestive system has apps to manage and monitor, right? It is amazing. There's lots of tools out here. And this is an opportunity for us to go and search for apps that is relevant to us, and that has that can provide us some feedback into our lifestyle, and go back and leverage that, and make use of it. Of course, some of those may be paid, but most of it is free. So if you want to download it, go download it and make use of that. And there are lots of other things that I could talk, and I had it as if time permits, we can talk about it. Again, the enablers are, there's tons of technology enablers that is out there in the market today. And one thing that I really wanted to talk about is teledoc. Um, teledoc is very relevant for today, right? With COVID, you don't know if your doctor and any of your caregivers has COVID, right? So if you go near them and if they are treating you, chances are you're getting COVID too, right? Or if you have COVID and if you go to a doctor for another condition, you are transmitting the disease. So teledoc was a thing at some point in time, but if you look at it now, these days, teledoc has become a huge hit. Like my last 3 doctor appointments was using teledoc, which is great, right? So you don't have to go to the doctor. The doctor can talk to you. You have a face-to-face connection. The only thing that's missing is examination, right? Last time when I did my doctor appointment through teledoc, I went to the lab and I provided blood, and the doctor had all the information in his hands, and it was amazing. So leverage teledoc if it's possible. And I don't think we'll have time to talk about electronic PA and e-prescribing, but electronic medical records, if you have an Apple Watch, it can take everything from your doctor. All you need to do is just connect to your doctor's EMR system, and then you can pull it down to your health app, and you can always have it handy, right? When you go to a different doctor, you can show it to him and say, hey, these are my conditions, instead of the doctor asking you, what do you have? Like, health terms are something that nobody can talk other than doctors, right? The doctor may say, talk about a disease, and you must have seen this in the movies, right? They always say something that nobody knows what it is. So there's no way that we as normal laymen can be expected to understand the medical terms and go back to another doctor and tell that. But in this case, we have a tool, right? Electronic medical records portability, right? We can pull it down, we can put it in your app, and the doctor can directly pull it from the records. And there's so many uh, things
Sir, your voice is breaking, sir. Sir, your voice is breaking, sir. Sir? Sumati ma'am, ma'am,
Yeah, I
sir,
can
voice
hear.
break ஆகுது.
Yeah, I can also hear.
Yes, yes.
Okay.
சார் இன்ஃபார்ம் பண்றீங்களா?
ஆமா.
பண்ணுங்க.
Hello.
Yes, sir. Yes, ma'am. Sumati ma'am.
Yeah, I informed.
Yes, yes. Shema, I think.
Oh, yes, sir.
Shema,
Yes, sir.
I think you can go to the next part.
Okay.
Yeah. Yes, go ahead.
Thank you, Jaya Play, sir. This topic is an apt one for this current scenario, and I think you are the very apt person who clearly explained every nook and corners in this topic so that many are benefited. Many participants have stated that it is a very informative session, and your explanation for their queries was awesome. Thank you so much, sir, for sharing your knowledge with us besides your hectic schedule. Thank you once again. May I now request Professor Gomati Nayagam, Head and Assistant Professor of Computer Science, to deliver the vote of thanks. Over to you, sir.
Thank you, ma'am. Good evening, one and all. Ladies and gentlemen, I deem it a great honor and privilege to propose the vote of thanks on this memorable occasion. Let me first of all start by giving glory to the Almighty God for making today's occasion a resounding success. First and foremost, we are grateful to our Honorable Secretary, Sri APC Chokaningam sir, for his words of encouragement. His able guidance always encourages. My heartfelt thanks to our brave principal for his stewardship, vision, and commitment. His motivation and unstinted support help us to reap success. Thank you, sir. I would like to take this opportunity to place on record our hearty thanks to our beloved director for his guidance. He has extended to all of us to make this webinar a grand success. I may like to express my sincere thanks to our resource person, Mr. Jay Pillai sir, the head of product management, Change Healthcare TBS, Virginia, USA, for giving an excellent coverage to the patient-centric healthcare administration. Despite of his busy schedule, he found his time to grace this occasion. Thank you so much, sir, for your interesting and valuable information. My sincere thanks to our IQAC coordinator, Dr. John Prince Soundaranayakam, sir, for his technical support to conduct this seminar a grand success. Thank you, sir. I owe a special gratitude to Professor V. Sumadi, of our department, who has worked to ensure that this occasion becomes a memorable success. My heartfelt gratitude to all my colleagues for their valuable contribution, guidance, and encouragement to us from all quarters. Last but not least, I thank all the participants present here accepting our kind invitation and making this function resounding success. Once again, I thank you all for your kind attention. Thank you, one and all. Sir Jay, sir, thank you so much, sir. Sir, your audio is muted. Sir? Yes, sir. Jay, sir? Jay, sir, can you hear, sir? Sir?
Sumati ma'am, thank you very much.
Thank you, sir. Thank you very much,
sir.
sir.
Thank
Jay,
you,
sir.
everybody.
Jay, sir, thank you very much. Thank you for spending your time with us. It's very valuable information we have got, sir. Thank you, sir. Thank you so much, sir.
I think he's in
Ma'am,
not
Sumati,
on
ma'am,
his here.
thank you for arranging such a great webinar.
Really thank you for
But I
everybody
think,
to support me.
Kandipa,
Really.
ma'am.
So I
But
can see video now, but I can't.
but
I can't hear
technical
anything,
fault da
and
konja
it's
problem
lost.
irundhuchu, but
Oh, it's okay.
yeah.
But overall, smooth நல்லா முடிஞ்சு.
So,
Jay sir, நம்ம
how
பார்க்க
was
முடியுது.
it? Good. You enjoyed it? Did you learn?
Yeah.
Good. Was Arjun watching?
He was watching a little bit, then he left.
Participants, the feedback link is on your chat box.
He said that he can see the video, but the audio is not connected.
Okay, ma'am. Shall we,
Say like thank you in the chat.
shall we end the meeting, ma'am?
Chat is disabled too.
Oh, right.
So I wanted to say thanks, but I can't. All right. Thank you, guys.
Jay sir, thank you so
Sir,
much, sir.
Jay sir, we can hear you. Jay sir, chat is enabled. We can hear you.
அவங்களுக்கு கேட்கலன்னு நினைக்கிறேன்.
ஆமா.
It's okay.
Hi, sir. Okay. Chat இப்ப enabled தான் இருக்கு. Chat is enabled.
They're still talking. Let me see.
Yes, sir.
We can do that.
Yeah, you can do the comments because I remember this happening in like.
Ma'am, Sumati ma'am, you can personally call him and you can
convey பண்ணி.
convey பண்ணிருங்க, ma'am. Yes, ma'am.
Hello? Hello? Well, எல்லாருக்கும் தேங்க்ஸ் சொல்லுங்க உங்க காலேஜ் அண்ட் ஸ்டாஃப். நான் தான் போட்டிருந்தேன் அதில், பட் ஐ couldn't say anything. எல்லாம் உங்க காலேஜ் ஸ்டாஃப். Oh, you can you oh, wonderful. So you can hear me. It's
Yes.
just that I can't hear you guys. So again, thank you very much. The
Thank you, sir.
administration and V.O.C. College professors and students and everyone that gave me this opportunity.
Thank you, sir.
This is amazing. And I'm glad that I was able to share my thoughts and ideas. And if you have any more questions, I am available, and feel free to ask those questions in the Telegram chat room. I am available, and I will respond to anything that I can. And thank you
sir.
very much.
Thank you very much, sir.
Thank you, sir.
Yes, participants, if you have any question, you can ask in the Telegram group we have. Sir is feel free to share his ideas. So thank you one and all. We will meet in the next another webinar. So thank you. Sir, Hema end பண்ணிடலாமா? ஐயாதுரை sir.
End பண்ணிடலாம் sir.
ஐயாதுரை sir.
Okay.
Okay sir, bye sir.
Bye sir.
Sumati ma'am, bye ma'am.
Yes, sir, bye. Sumati ma'am, bye.
Cedric sir, bye. Cedric sir, bye. Sumati ma'am, bye ma'am.
Cedric sir, bye.
Bye.
Cedric sir, bye. Meena ma'am, bye.